And I don't know what you say, this would be interesting, maybe we'd say different things. I'd probably say, why don't you do this, why don't you talk to the family, say, would they be comfortable with a trial intubation? So it sounds like to solve this problem, you need to do what you gotta do, intubate her, and then when they get to the hospital, let's say, well, we're gonna give it 12 hours or 24 hours, so it's not gonna be a forever. I think that's what people say when they wanna be on machines, is they wanna be on a machine forever, but if it's 12 hours or 24 hours to get back to how they were, fine. Now the family's like, she wasn't happy how she is. She's in memory care, doesn't recognize any of us. She doesn't even want to be back to here, because we never make people better, right, by intubating them, or CPR. Then it would probably be different. And I mean, it would be hard to give you these orders, but I might tell you, we're gonna give her 100 of fentanyl, and we're just gonna keep her comfortable and go ahead and transport. But like that's like end of life care, and that's what you do for end of life care sometimes.
Use your judgment. Do what you think is reasonable, for sure, in this instance, which you did, I think, very well. Even though there wasn't a DNR present, you know. You guys have all been doing this for a while. You develop some judgment, and just do what you think is reasonable, and then document that. You know, I think most often we'll back you up on that for sure. So if you're doing something that any other reasonable medic would do for that person. So always err on the side of life, for sure. So.
And just bring one of us in on the radio when it gets dicey, because then the liability's off you and it's on the dock. So.
Just because I can pull tapes, I pulled it. So let's listen to the MRCC report.
912 station information for regions, Red Medical.
Right there for regions, go ahead.
71-year-old female coming from CCU, choked on a piece of chicken. Staff was attempting time as when we arrived. She was GPS about 6. We were able to clear the obstruction with McGill that had to RSI her. She is currently 90% with DVM, ongoing 100% oxygen. Egg title initially was about 16, now 45. 140/69 for lapse pressure, and 94 sinus rhythm on my monitor. We'll be there approximately 10 to 15 red for region.
Copy, 174.
Kudos to you for calling somewhat early. For sure.
Definitely saved that patient's life, like no question, no doubt, clean save. So that's what we train for. You guys should feel really good about that. And you absolutely saved that patient's life.
Did you get follow-up?
I haven't, yeah.
So this follow-up is from 2 days ago. So those were her vitals when she got on scene, which pretty good, little hypotensive. She had bilateral breath sounds, weak pulses, oxygenating well. The tube was in a good spot. They didn't need to reposition it after they checked. Her labs, she's a little acidic. So how do you treat a patient in this instance when they're a little acidic? Oxygenation. So making sure that you're paying attention to the capnography reading that you're getting good squeeze of that bag. Remember, do you guys have the PEDS small adult bag, the blue one? So remember, getting a good 2-hand squeeze of that bag and doing it at an appropriate rate. You're not going to give her a pneumo from getting a good full squeeze of that bag. You're going to be worried about barrel trauma when you're squeezing it too fast, but not an appropriate tidal volume. So as of the next day, she had equal and reactive pupils. She was following commands, able to give a thumbs up, wiggle her feet. She was still on a vent. We can actually, let's look her up right now and see how she's doing.
She is on room air.
There you go.
There you go.
Save that lady's life.
Nice work, guys.
Feel good about that.
Mm-hmm.
Just have to see how the aspiration pneumonia that sets in will do.
Well, John Romero, that's pretty good.
Yeah. Small ones.
So briefly, let's go over our RSI checklist real quick. Hopefully you guys have seen this. I know if you've been through Critical Thinking Lab, you have seen this. This is a checklist that's been around for a while, and I really like these checklists. The service I came from kept it on the wall above the counter so that we could always make sure that we were doing these things before we pushed medications on them. Recently, what we've added to this is mandatory minimum vital signs. So we want to have people's SATs of 95 or greater. If we RSI patients that aren't in the mid-90s, let's say we've got SATs of 80, as soon as we push those medications, those RSI medications on them, their SATs are just going to plummet immediately. So they're going to get real hypoxic, get a brain injury, and then maybe be peri-arrest. So it's on us to do as much pre-oxygenation as possible. So getting the nasal cannula on there quick and cranking it up while they still have a respiratory drive. Putting that non-rebreather on there. If we have to, we will use the bag valve mask and assist with their ventilations to get their SATs up. Being careful that we're not bag valve masking unnecessarily, because inevitably, no matter how well we're doing it, we get air into the stomach and things are going to get messy. But also getting patients' blood pressures up to at least 90 systolic, and there's some in the office that say it should be 100 systolic. If we push drugs on somebody whose pressure is in the tank, it's going to go even lower, and they're going to cardiac arrest sooner on us than they normally would. So remember to resuscitate before you intubate. Let's say we're doing our best efforts and we can't get those SATs up. What can we do? We have a tool in our bag that we rarely use or rarely emphasize. So we have RSA. So if you've done your best efforts, you cannot get their SATs into the mid-90s, you can push your medications, you can push your ketamine or etomidate, give your vecuronium, and then drop an iGel in, and then hopefully get their SATs up with that iGel. So we can't use an iGel prior to that, right? Because they're either clenched or they have a gag reflex. But so we'll push the induction med and the paralytic and then get that iGel in there and then hopefully get them up into the mid-90s. And then at that point, if we have enough time and enough personnel on scene, we'll replace that iGel with an ET tube. The ET tube is a definitive airway, whereas the iGel is not so much. So with an iGel in, they could still aspirate. We're not getting airway pressures that we want to get with that. So use the iGel and the RSA as a bridge to get to RSI. That intubation. Make sense? The rest of this list is just the equipment that you should have next to you in case you get in there and you're surprised by some sort of anatomical anomaly or something like that. So, if you don't have this checklist, I'd be happy to email it to you.
I think you did last time when we put them both in the trucks.
Oh, good.
Or at least in the, like where the RSI meds are.
Okay.
2 of them. There's like a couple sheets of it's laminated.
Good. If you leave here today with anything, it would be to hopefully have these mandatory minimum vital signs in the back of your head. So, oxygenate them up if you know that you're going to paralyze them. Thanks for looking that up, Dr. Hardy. I didn't see your ultrasounds on the site, so we should look into that. But hopefully you have this quick reference card in with your machines. If you haven't done an ultrasound in a while, the purpose of this is to kind of help you get through that so that you do use it. It's to standardize it so that all of us are doing it the same. So once you get your iPad or whatever you're using up and running and you've got your probe ready to use, put gel on it or the patient, go to your preset, which that's the button right there, and then you're gonna click like cardiac view. And then remember, even though you're seeing what you need to see, make sure that you record that attempt. So if you hit the record button, it will record for however long that little number, that the 9, is in that little circle. If you hold that button, it'll bring up a drop-down menu with different times on there. We don't need to see a minute or anything longer than 6 to 9 seconds. So it can just be 6 or 9 seconds. That's enough to see lung sliding. That's enough to see squeeze with the heart. And then once you do that, you can carry on with your care. Once you've seen what you need to do with your ultrasound, you can just put that machine down and leave it. When you have time, you get back to the station or you're driving back from the hospital, make sure that you go up into the upper right corner and there'll be a blue box, and the number that's in that blue box is the number of scans that you have, and then it'll bring you to your worksheet. And then number 5 here is how to fill out that worksheet. So patient details, we don't need any identifying patient demographics in there. We just want your incident number in there. So then we can go back and reference it to the chart. Your exam type is simply the preset that you used. The worksheet is to be filled out by your ultrasound champ. So you don't have to worry about the worksheet. Notes is your opportunity to go in there and explain what you saw. It doesn't have to be super detailed. You can just go in and say PEA arrest, we saw cardiac squeeze and transported to Regions. It can be something simple. You can also elaborate all you want in there. The more the better. And then once you've done those, scroll down to the bottom, hit Save Study, and then you guys are going to hit Save as a Draft. So I suspect that's where yours is living right now, is in that draft section. Your champ needs to go in, fill out the worksheet, and what they do is they go in, they look at your scan, they agree or disagree with it, and then hopefully give you some tips. And then they will save it as a signed copy, and then Regions, the docs, are able to see it. Make sense? So all the services have this quick reference sheet, and we're hoping that everybody's using it just like this, so that it's easy to use, it's referenceable, it's all standardized. Make sense? Cool.
The only thing I noticed is the recording button went away when I put it on M mode,
Yes.
so I wasn't able to record on M mode.
Yes. Right. Doesn't save that snapshot, I don't think. So.
I let Jay know what I thought I saw, and he double checked, so.
Good. Cool. Use your partners.
It was kind of, I was doing the stuff with the lead course the other day, with just some like lay people, like civilians, and it was kind of neat because we had the ultrasound, and so we would show them the artery, the brachial artery pulsing away, and then they put the tourniquet on, we show them the artery again, and it wasn't pulsing, and you let it down a little bit and see it start pulsing, and it's just kind of cool what you can do with the ultrasound. Like, people who are visual learners just get things. Like, you could have them feel the radial pulse, and oh, it's gone and everything, but some of the people just really seem to get it better when they could see the artery moving and then not moving and all of that. So, as you guys are teaching or doing stuff with your community, things like that, just keep that in mind too. It's good practice for you guys, and like I said, some people just seeing it just clicks better. And when I'm using it during cardiac arrests, like it also can be pretty helpful to show the family and stuff. Like you don't have to be a medical provider to see a heart that's not moving, and you just get it a little bit differently. So just keep that in mind. That's a tool you can use as you're setting patients up where you're going to stop terminate arrest. I'm seeing the heart rate here is not moving. I'm going to talk to one of the doctors at the hospital, because I think they're going to tell us to stop.
We have a newer person in our office, Wes Halverson, and he is taking over the initial ultrasound class. Our office is going to be giving that class from now on versus Regions giving it, and hopefully we are revamping the course to make it, I think, a little bit more medic level, for sure. I think that we all needed that. One of the things he's showing is a round-the-clock view that you can do with your probe. So it's not just, you don't have to just do the subxiphoid view, which can be hard to do. If somebody's got a really full stomach or maybe a big stomach and you cannot see what you're looking for, you can do an apical view. So you can put that in between the ribs at like the second or third intercostal, and you can hopefully see the heart from there. So there's different stuff that you guys can do with the ultrasound now and using different spots. You're not limited just that subxiphoid view. Myself and Wes is an excellent teacher. He's very enthusiastic, and he'd be more than happy to come out here for 30, 60 minutes and show you some of those additional views that you can do anytime. Like, seriously, we can come out to shifts if need be, so it doesn't have to be like a special thing. So let us know. With that, that's all I have for PowerPoints and other things for you. What I do have is just some odds and ends stuff. Just want to remind you that ECMO is the best tool that we have for our patients that are in VFib, VTAC arrests. Remember the inclusion criteria: 18 to 75-year-old patients, viable patients. They don't have a DNR, DNI. They're not, they don't have terminal cancer, that sort of thing. We want patients that are getting high quality CPR, so making sure that they can fit into the Lucas device. They very much prefer intubated patients so that they know that they're being well oxygenated, and that the pants are cut off. So they can cannulate somebody pretty dang quick once they get them moved over. So we've gotten good enough about bringing them people that the advice they're giving us now is that their pants are cut off. They can have somebody cannulated within like 2 minutes of moving them over. So make sure that you expose their lower half so that they can get to that femoral artery so that they can cath it. Those inclusion criteria I refer to as rules made to be broken. So if you have a 78-year-old witnessed arrest that got CPR immediately and you're feeling pretty good about this patient, you can get them off the scene and moving down the road pretty quick, call and ask if they'll take them. If you are on your way to a call, cops update you that they've shocked this patient once, start thinking about getting that patient moving as quick as possible. So get them on the board, get an iGel in, get them on the board, drill them, get an epi, and get them moving as fast as you can. Remember to switch over, if they ask you to switch over to an STAC channel, please do that. It's not just to give a second report. You will actually talk to somebody on the mobile ECMO team, and they can give you real-time instruction for that patient. So if, let's say you've got ROSC on that patient at this point and they maybe need some sedation, they'll tell you exactly what to give and what dose. So switch over to that STAC channel. If you don't know where that is on your radio, take some time to figure that out. If you ask me to switch over to my STAC channel right now, it would take me a minute to find what bank it's in. So be familiar with that. Your first set of defib pads, where are those going? Where's the big pads going? A and P? Yep. So the reason for that being that if you need to put a second set of pads on, so you can do either vector change or dual sequential defibrillation, you can do that real easy once the Lucas is on there. You can slap those pads on right around that Lucas. So remember, after that third failed shock, to convert them to a perfusing rhythm, you want to do either vector change or dual sequential defibrillation. Any questions on that? Hopefully that's a standard at this point, that we're putting those pads on in the anterior-posterior position. Dr. Jason Bartos is a cardiologist, and he stated that he's been using that pad placement for a long time. He says they just work better, so remember that. For your cardioversions, for your defibs, that sort of thing.
He's one of the ECMO docs too. That's how we do it in the ER. Like we shock a lot of people out of like AFib. That's probably the most common thing we do, but I don't know, I always put the patches. I always have AP for that. So it just seems to hit the heart better.
Makes sense. Travels right through it instead of kind of going around it. Droperidol. In the last update, a precaution was added for droperidol. Remember that we don't give droperidol to Parkinson's patients. They already have a dopamine dysregulation, and if we give them droperidol, it's going to make their symptoms a lot worse. So if you have a patient with Parkinson's and they need some sedation, a little bit of Versed. So just think, droperidol, don't give to Parkinson's. MRCC, we already went through the triage colors. They very much want you to lead off your report with the triage color, because then they bring up that specific template. So if you can tell them that you're bringing a yellow patient right away, that'll make it easier on them. If you give it last, then they have to sit there and listen to your whole report and then bring up the template. So
I got one thing I'll hop in while you're looking.
please do.
So those of you guys who knew Dr. Frasconi, so certainly my mentor, was the medical director here at White Bear and at Regents for 42 years, I think he worked there. We just gave him like a Lifetime Achievement Award. He really helped get the mobile ECMO program up and running with Dr. Yiannopoulos. It was really the two of them. So he just got, we called it the ECMO Heartbeat Award from the hospital. So it's good to see him. He's in retirement now. Had a few health issues, but is bouncing back really well. So I just thought I'd pass that along for those of you guys who knew RJ. So he's doing good. We gave him a Lifetime Achievement Award, and so it's certainly well earned.
Yeah, that's very cool. Well received, well earned. Stroke codes, remember that you can call stroke codes up to 24 hours. Patients with onset of symptoms from 0 to 4.5 hours have to go to, or can go to a stroke-ready hospital, which is any of the ones that you guys are going to transport to. They'll take them to CT right away, see if they need thrombolytics, and then administer that. If the symptoms are outside of that 4.5 hour window, up to 24 hours, they need to go to a cath lab-ready hospital. So, what are our cath lab-ready hospitals?
Regions, United.
St. John's. St. John's, yes.
Last one's always iffy, where I was like,
Yeah, everybody kind of does that. St. John's? So the reason being, they have cath labs. They can go in, they can do a thrombectomy, and they can hopefully grab that clot and pick it out, and then patient can have some sort of recovery from that. Shortages. It sounds like droperidol is no longer on short. I don't know that it ever was for you guys. Amiodarone is short indefinitely.
saline,
Saline is no longer short.
strategy.
Give people some fluids. D10 is intermittently on shortage. You might get a vial of D50 in its place, so that big blue
Still okay to
box.
use expired?
Sorry?
Still okay to use the expired ones?
That's a good question. Anytime those drugs are super short, they usually extend the life on those.
Got extended 9 months on D10.
Oh, good, good. If you do get the D50, just remember, push it through a patent IV. Make sure that that bag is patent for sure. So how can we do that? One of the easiest things that I always did is I would just take that bag from the ceiling of the ambulance and put it on the floor or close to the floor, and blood will back up a little bit, and then just raise it back up. You can draw back a little bit if you want on a syringe, that sort of thing. But very simple to just grab that bag and put it down on the floor. If you're up against a valve or something and it's not flowing great, you might not get a return, but Insolumedrol is on shortage as well. That's what I got for you guys. You guys have any questions?
Yeah.
Yeah.
So have you seen those, I don't know the exact name for them, but those things that they use to like suck things out of people's airways, usually for kids, or it's advertised to kids?
I've seen it. I've seen it advertised on.
I've had several people
Facebox.
ask, do you guys carry those? And I'm like, no, we don't really have them. So I'm just curious if you guys have seen or heard or thoughts on those at all.
I have not seen them anything outside of advertisements.
Sure. Okay.
So-
in the United States, healthcare is a business, so there's always someone looking to sell you something.
Yeah.
We've looked at them. I agree. We get this from a lot of services. Citizens are asking about it. I don't think the company that makes them will give you some data, this, that, and the other. What I can tell you is like the Heimlich maneuver has been tested over generations, and it's definitely standard of care. So I don't think there's a need to invest money in training and everything else in that when we have a perfectly acceptable alternate that works well. So we're aware of it. We have explored deploying them, and we feel that the Heimlich maneuver is still the appropriate thing. Like I would never tell you to not do that Heimlich and go to that.
Yeah.
And then especially, I think the area where it's a harder argument to make is in a BLS only service where they don't have the ability to use McGill's, but as an ALS service, you guys have the ability to use McGill's. So again, I would never tell you to skip the Heimlich and go right to that first, and I would never tell you to delay using McGill's to use that. So that's kind of how I would approach that.
Thank you.
So there's lots of cool stuff out there. There's always latest, greatest coming up. And there is a medical device policy. And we want to hear when you guys find stuff, because we can't hear about everything for sure. So when you guys do see something that looks really cool and you think it might benefit your service, let us know. Let's research it together. Before you would adopt something like that, obviously you would need medical director approval. So let us know. Let's look at it together if you see something that's cool and it's worth exploring. So.
And I think we're pretty willing to let individual services trial things. Like if someone felt really strongly and you guys are willing to do the training time and everything else, I think is we're pretty open to stuff. But it's always a balance. We have device companies calling us every week wanting to show us things. Like, and the number of supersonic airways that are out there is just amazing. And if you think about it, like, they could sell it to, what, 4 hospitals, 5 hospitals in the East Metro, or they could sell 5 to you, 15 to St. Paul, 5 to Cottage Grove, 5 to, you know, so I mean, the market is in EMS, so they want to get all this stuff. So that's where we try to put a wall and really stick to the science and what's been proven.
That the third page of the medical equipment policy has some details on that, if anyone wanted to nerd out and read that. So with that, you guys are doing good work. We appreciate it. You guys are ready to give acetaminophen. You've got it. You've got the tubing. I'm excited for you guys to give it to a couple of people, for sure. I don't know, we don't have any chiefs in here, so I don't think, we'll ask them when they plan on putting it in the truck, but if you give it to somebody, please let us know. This is exciting. I'm pumped about this and I want it to work good.
Me too.
So, I'm anxiously waiting for you guys to give it to somebody that needs it. We have, believe it or not, somebody who wants to take the written RSI test. So we're going to do that. Any of you guys want to take it, you certainly can. It won't count, we won't record your score, it won't go on your file or anything, but you guys are welcome to take it if you want to. Emma? She passed it, no problem last time, but she didn't get 100% and she wants 100%. So we're going to let her retake it. All right, everybody sign in. We good?
Thank you.
Okay. Cool. Thank you, guys.
I just have, I just knew the French guys carried it very recently.
Did they like it? Did they say?
They loved it.